Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. This episode is sponsored by meded101.com. Please go to meded101.com/store. Go check out all the resources there. Tons of books, study materials, all that good stuff. NAPLEX exam, ambulatory care, BCPS, pharmacist and pharmacy student content. We've helped thousands of pharmacists prepare and pass their board exam and can definitely help you too. If you're another healthcare professional, pharmacy technician, nursing student, med student, definitely tons of books on pharmacology, resources. Go check them all out, meded101.com/store. All right, so the drug of the day today is fluphenazine. Brand name of this medication is Prolixin. And the class of this medication is a first-generation antipsychotic. It is what's called a phenothiazine derivative, which that gets into kind of some of the biochemistry and the molecular structure of the medication, if you will. Not going to go do a deep dive into that, but it is a phenothiazine derivative. What is this medication used for? Obviously, it's an antipsychotic. So we're going to use it for schizophrenia, bipolar disorder, possibly, various states of delirium due to various things and other agitative states. Also can potentially be used for tic disorders. That's an off-label use. Again, this being a first-generation antipsychotic, it's not one you're probably going to see a tremendous amount in practice. The most common scenario that I've seen with fluphenazine is patients that have been long-term kind of schizophrenic patient that has been stable for a really, really long time, and this medication has been effective for them. So that's probably the most common situation you're going to encounter versus a brand new start. Again, you may look at that if patients, failed a bunch of different medications, and we may consider this one, but again, it being a first-generation antipsychotic, it has a lot more extrapyramidal symptoms, which I'll get into as I talk about adverse effects, of course. So let's talk a little bit about dosing. So, treatment of psychosis. We do have an acute IM formulation. With that said, there's also an IM formulation that is an extended release formulation. So make sure you are well understanding of that. If you're using this medication, prescribing it, dispensing it, whatever the case may be, we've got to recognize that we've got more of an immediate action IM formulation, and we've got the long-acting injectable formulation as well. Okay, so don't mix those up. Be sure you know what you're doing with that. There is also oral dosage forms. The oral dosing is anywhere from 1 to 40 milligrams per day. Patients who are maybe newer to an antipsychotic, you probably be, less aggressive, a little bit more cautious about the dosing. As we get up to higher dosages, that dosing may be split into twice a day. At lower doses, it might just be once a day. So again, kind of patient specific, depending upon what's going on with them clinically and how they're responding to the medication. All right, for the intramuscular formulation, that's the extended release formulation. So that's fluphenazine decanoate. That's the extended release or the long-acting injectable suspension. It's important to establish tolerability to short-acting fluphenazine first. Okay, so really, really important before we give them this basically injection that's going to deliver that drug over a long period of time. We want to make sure that they're tolerating the medication first, okay? Because obviously that presents a huge issue if you just give them the long-acting IM and they're not tolerating it very well. Well, you can't take it back, and they're going to get that medication, over the course of weeks there, that the med is going to be delivered. So really, really important to remember to assess tolerability and make sure they use immediate release or oral or whatever to make sure that they tolerate that medication first by using the short-acting before we give them the long-acting injectable. With that long-acting injectable, we tend to do oral overlap typically. So that's like with the first injection, we still might give some oral medication there. Usually it's in the neighborhood of half of the kind of previous daily oral dose. And then when we get that second dose going of the long-acting injectable, then we are typically going to discontinue that oral medication there. Mechanism of action, I kind of skipped over a little bit. Hopefully, you can kind of recall any antipsychotic is going to have dopamine blocking activity. So particularly, it's the D2 receptor. Definitely a great board exam question or pharmacology exam question. So it's the dopamine 2 receptors in the brain that are blocked by antipsychotics. With fluphenazine, it has less activity or minimal activity on histamine receptors, muscarinic receptors, as well as alpha receptors. So as I get into adverse effects here, this is a nice transition, the antihistamine activity, so that's the sedative properties, fluphenazine doesn't tend to be as sedating as some of the other agents. It can be sedating, but because it lacks that histamine blocking activity, we may have less sedation there. Okay. Same thing with anticholinergic activity. Not as bad as some of the other agents. And then we don't have as much alpha blocking activity as well with this medication. So from a low blood pressure, hypotension standpoint, we're not as likely to have that issue compared to some of the other antipsychotics. What we do have a lot of with fluphenazine, as you could anticipate it being a first-generation antipsychotic, is the extrapyramidal symptoms as well as the risk for TD. Okay, so because it's such a potent blocker of dopamine 2 receptors, this is the major issue, and this is why you don't see these medications used very often, because those extrapyramidal symptoms can be really, really bothersome, as well as obviously not look visually appeasing to somebody that's, to a family member, caregiver, those type of things. So, that's the big reason why those first-generation antipsychotics like fluphenazine aren't used terribly often. I did want to mention there is a warning on increased risk of death in elderly patients with dementia-related psychosis. That's kind of standard with all antipsychotics. Some other adverse effects, things to think about, elevations in prolactin levels. Fluphenazine tends to be higher risk for that. So in patients, particularly maybe male patients with sexual impairment, that could be a big issue of exacerbating that, because it does elevate prolactin levels pretty significantly. And then you've got kind of all your other antipsychotic adverse effects. The EPS and tardive dyskinesia risk, that's going to be very, very high, which I alluded to before. Some of the other ones may be less common or not as common with fluphenazine as some of the other antipsychotics. Sedation, QT prolongation, weight gain, metabolic syndrome, glucose abnormalities and elevations in lipids. Those are probably a little less common with fluphenazine compared to other agents here. All right, then we've got pharmacokinetics. Wanted to mention that very briefly. CYP2D6 is an important enzyme in the breakdown of this medication. Okay, so we'll get to drug interactions coming up here, but that can definitely be a concern, or at least something to think about and pay attention to. From a patient standpoint, definitely important to educate them that benefit typically isn't going to be instant. It may take a week or two, up to maybe a month or two for kind of that full effect to take place. So good patient education, caregiver education point there, making sure that they recognize that it's not going to be an instant fix, for example. A couple considerations, extra things that I did want to mention. So we use AIMS or discus sometimes to monitor for tardive dyskinesia and movement disorders, those type of things. So those are a couple of assessments that may be utilized. Neuroleptic malignant syndrome, it is a potential adverse effect, very, very rare. But what you're going to see is fever and typically muscle rigidity with neuroleptic malignant syndrome, and that can happen with antipsychotic. Younger patients and higher dosages, that's where we're going to probably run the highest risk of running into that clinical situation. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're a pharmacy technician, we just released a new course, 8-hour course, that's meant to prepare you for the PTCB exam. So go check that out on udemy.com. It's called the Pharmacy Technician Bootcamp by Eric Christensen. Definitely a great resource, lots of high ratings. People are really enjoying it. So go check that out on udemy.com. All right, so finishing up here on drug interactions. First thing I think about kind of with antipsychotics in general is that dopamine blockade. So a medication like metoclopramide can exacerbate that dopamine blockade, increase the risk for extrapyramidal symptoms, for example, maybe even neuroleptic malignant syndrome. Definitely metoclopramide's a medication that we probably want to avoid altogether in a patient taking fluphenazine. Okay. Also, other antipsychotics, using multiple antipsychotics together, I have seen it occasionally, but keep in mind, the more and more dopamine blockade we get, the more and more likely you may run into some of those adverse effects. Now, on the flip side, let's say we're trying to treat Parkinson's disease with a medication like Sinemet, so we're trying to increase dopamine. These medications can actually kind of counteract each other. So fluphenazine can make Parkinson's symptoms much, much worse, some of those movement symptoms of Parkinson's. So that's going to potentially counteract any benefit that we're trying to get from Sinemet. All right, those CYP2D6 inhibitors, I alluded to that before. Your paroxetine, your bupropion, those are a couple classic examples of medications that inhibit CYP2D6. That's going to potentially raise concentrations of fluphenazine. So definitely one thing I pay attention to there. And then we've got QT prolongation risk. So if you got a patient on antiarrhythmics, maybe some of the azole antifungals, macrolide antibiotics, these are all medications that could have additive effects on top of that QT prolonging action of some of those other medications like fluphenazine. So pay attention to that. Typically, we're going to monitor EKG. Maybe you have a baseline, and if you got a patient particularly at risk, maybe monitoring that periodically as well. And then the other thing I will mention, it's probably less common with fluphenazine, but it does have some CNS depressant activity. Again, maybe milder than some other agents. So anytime we add an opioid, gabapentin type medication, a sleeper type medication, we could certainly have some additive effects there. And then the anticholinergic activity, again, not real strong with fluphenazine, but could mildly add to that anticholinergic burden of a medication like oxybutynin, for example, or diphenhydramine. So something to pay attention to anyway there. All right, well, that's going to wrap up the podcast for today. Do me a huge favor. Go to reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Please leave a rating or review on iTunes or whatever platform you're listening on. I greatly appreciate that. Okay, so please do that. And, of course, share us, friends, colleagues, students, anyone who could benefit from pharmacology education. With that said, I'm going to sign off for today. If you want to reach out to me, mededucation101@gmail.com, or you can contact me and connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Signing off, thank you so much for listening. Take care and have a great rest of your day.